This conference will now be recorded.
And I'll say who I can see. I think I've got everybody: Jake, Carl, Joel, Blanchette, Len, Les, Rich Jackson, Larry, Sylvester, Paul Frieda, and Bob Bordiger. Did I miss anybody? Good. Well, we have to start with sad news, I am afraid to say. I don't like having to announce at the beginning of a call, but yesterday I got an email from Jake, and we learned that we lost Thibeaux on, I guess, Sunday night. Is that right, Jake? I was trying to figure it out. It was Sunday night, right?
Yes, the 24th.
Yeah. I don't know a lot more. I was just looking at my notes, and looks like the last time we spoke to Thibeaux was in September, and he was talking about doing some immunotherapy. I don't even know if Dr. Denmead knows. One of the things I planned to do today, and it got away from me, so I'm going to do it, is I'm going to send Dr. Denmead a note tomorrow just to make sure he's heard. You know, you never know with the doctors. We don't know where he was, if he was hospitalized or what.
No, according to Jackie, she wrote an email. Apparently he died at home in bed. His two sons had a chance to cuddle with him before they went to bed, and then he died shortly after that, with Jackie by his side and somebody that she called grandmom, somebody or other. So he wasn't home, as far as I know. And as far as I can tell, he died peacefully, which is a blessing. And his kids got to say goodbye to him. They probably didn't know they were saying goodbye to him, but they cuddled with him before they went to bed, and then they went off to bed, and that's later on he died. So.
Do we know from the Facebook posts if he had been just deteriorating, or if this was sudden, or do we know anything?
No, she didn't really say. She just said he didn't want to die, and he was, he wanted to keep on fighting, but his body just gave out, was the way she put it, I believe. Yeah, I'm paraphrasing, but it's something like to that effect.
Yeah, no, I mean, I think we knew that. I mean, we could have written that ourselves.
Yeah.
When was the last time he posted on Facebook or on his Facebook page before today?
Yeah. I'm not sure, but it wasn't that long ago. I think I could double check. Let me go take a look while you're talking to everybody else.
Okay. Well, you know, as we like to do with our guys who have been with us a long time, as Thibeaux has, I'm just looking here to see. I mean, I remember meeting Thibeaux myself when I went to DC for a conference, and that must have been 3 or 4 years ago. And he'd already been with us quite a while. So, you know, I do like to open it up to let anybody who's on the call pay a tribute to Thibeaux, and you know, I'll round it out. But Len, you've said some pretty poignant and touching truths. Maybe you just want to kick off, and then anybody else who wants to say anything for Thibeaux, please do so. But Len, why don't you kick us off?
Yeah, I didn't know Thibeaux very well, but the few times he was on the call when I was also present, knowing the steep odds that he faced, he always seemed to demonstrate a complete acceptance, even while he was fighting his hardest to overcome his illness. And there was a certain sense of honesty, dignity, and elegance, I would say, in the way he would present his situation to us. So I was an admirer of Thibeaux, even though I didn't know him very well.
He was 48, by the way, if you're wondering when he passed. He was 43 when he was diagnosed.
Right. Yeah, he was born the year I graduated from high school.
Wow.
To answer your question, Rick, apparently I think he posted the last time in 19th of October.
Mm-hmm.
I had to go through a lot of posts because everybody's putting tributes to him. But he was quite an accomplished guy. He was a tech consultant at Oracle. He was a photographer. He was a veteran. I believe he was Navy, but I'm not quite sure. It might have been Coast Guard. I have a hard time with those uniforms. He actually ran for Congress in 2008 as a libertarian. These are all things that I found out afterwards. Been kind of, scrolling around and looking him up. I wish he would have won because the idiot that got elected was horrible for Maryland. But yeah. So he's quite an accomplished guy for his age, especially, and apparently very much loved by a lot of people because there's a lot of comments on his Facebook page.
Jake, will you be sure to post something from ANCAN on there, please?
I did. I already did.
Thank you very much. Thank you.
I put it there. I put a couple things on Facebook for him on, in memoriam, that kind of thing. So, but yes, I did put something on Facebook. I posted a Jackie's comment.
Yeah, we're adding him. Unfortunately, I can no longer add the in memoriams myself. It's it's beyond my web knowledge. So I've sent it to Jackie Zimmerman and she'll get it posted. Hopefully she can teach me how to do it, but it's a little too complicated the way it's formatted. But
right.
She has the information and he'll get at it. And we're also going to replace the picture of Professor Bill with a much more appropriate one that you'll find it on there. Is there anyone else who would like to say anything about Thibeaux?
Let me just tell you what I wrote before you go to somebody else. This is what I wrote on Jackie's timeline. I am so sorry for your loss. This is from me. It wasn't from ANCAN. I am so sorry for your loss. I knew Thibeaux through ANCAN. We always enjoyed his company when he joined us online. All of us admired him for his strength in fighting PCA and for his obvious devotion and love for you and your boys. Rest in peace, brother. So it's not exactly from ANCAN, but I did mention us.
Could you do one from ANCAN, from our ANCAN site? Or is that not?
I can try. I'm not sure, Rick, if I can.
Okay, well, if you can, fine. Don't knock yourself out, but if you can, that'd be great. If you cannot, that's fine.
All right.
Anyone else like to just say anything about Thibeaux before we get into the meeting?
Just to add myself, it's clearly a loss for everybody here and everybody who has participated in this forum. And the few times that I participated, I do recall him. And my immediate thought was I recall that him being quite young and so horrible that for someone at age 43 to be diagnosed and clearly passing away at age 48 with young children, it's so I don't know what other word to use other than very disturbing that that affected someone that young and that vibrant. I don't recall if anyone else in this forum, and maybe Rick from several years, I would expect it's quite rare for someone to be stricken at that age.
Yeah. That's probably true, yeah. Rick, could you post his full name in the chat window so I can go look at his Facebook page and make an entry also?
Yeah, Jay, would you do that? Would
Yep,
you
I
mind?
got it.
Thanks. Yeah, how rare is it? It's not. It's getting less and less rare, unfortunately, Carl. I mean, this is why we've just started this under 60 metastatic advanced cancer group. You know, even if I go back a while, when I think about when I first started doing these groups in 2010 with John Teisberg, there were two guys on his forum who were very young. One of course, was Rob, who was diagnosed in his, I think, 47, maybe younger, maybe 44. I'd have to look it up. And then there was another guy, James, I forget his name. I haven't heard from him in years. He lived in the middle of nowhere in Ohio. But now, yeah, we see a lot of guys. I mean, when we did our first dress rehearsal for the younger guys last week or the week before, we had about 6 or 7 just from our own ANCAN forum, and we haven't advertised it at all yet. And the sad part is it's just getting more and more prevalent. I mean, the strange part with Thibeaux was that they never really identified a mutant variant. I mean, they did, but only, you know, the stuff we often see like P10 and TP53. But we never really saw anything. I mean, he did eventually get sequenced P10, TP53, and then some variants that just don't mean a lot to me. I think they might be subvariants of the androgen receptor, but they didn't mean a lot to me then. They didn't mean a lot to Professor Bill, God rest his soul, because we passed the report by Bill, I remember. I mean, for some of you who don't know, Thibeaux tried pretty much everything. And the most radical, subsequent to Dr. Denme doing a presentation on our site, Thibeaux reached out to him, and he finished up entering a trial where they replaced all his bone marrow. I believe it was from a female donor. It took a long time to find the donor, and the idea was that it might make his androgen receptors more responsive once they'd become resistant. And he got several months, maybe a year, one way and the other. But he went through hell with that bone marrow transplant and graft versus host comorbidities. So it was just rotten fractures. I mean, I'm just looking. One point he lost a huge amount of weight. I mean, he just went through everything, and nothing stopped him. I don't know. I mean, he was an interesting guy. I remember one time he showed up when he was laid out in bed, and he was completely tattooed from basically his neck down. So I suspect that has something to do, or it may not, but it may have had something to do with his military service wherever he was. I don't know. I shouldn't make that assumption. But anyway, and I don't know what his military service was either, but I have a feeling it was intelligence related. Whatever service he was in, I think it was intelligence related. I think he might have told me when I actually met with him and had dinner with him in DC. That was when he was living in DC, and then he moved the family out to College Park, Maryland. And that's where he's been for about the last 3 years. We'll miss him. We will definitely miss him. And Jake, if you, as and when you track down the obituary, will you let us know and we'll circulate it?
Yes, I will.
Thank you.
You know, I just Googled his name, and one of the first things that came up was a article that was written about him from Cure magazine in 2017, and how he basically said that he decided his doctor was an idiot, his urologist, because he didn't want him to have a PSA test, he didn't want him to have additional diagnoses. He dismissed the results, prescribed him antibiotics. So that was really sad to hear.
Yeah, thank you for reminding me. I have that article bookmarked somewhere, and I think we circulated it. I remember I mentioned it in the in one of our reminders, and I will use it, and we'll make a post in the blog, and we'll put it. We'll use that. We'll use that to do it. So yeah, thank you. Okay. Anyone else want to say anything before we move on?
You know, I'm just wondering if the urologist almost refusal to even consider the fact that he may have had prostate cancer and that he was treating him for prostatitis is kind of emblematic of people, even doctors, thinking of prostate cancer as an old man's disease, when in fact we know quite a few guys who are first diagnosed in their 40s. And recently I've heard some even get diagnosed in their 30s.
Yeah.
Yeah, and I forgot to say, too, that another reason I admired Thibeaux is he was really quite a pioneer, one of the very first, if not the first, to undergo the bone marrow transplantation. I'm sure he knew the chances of success were slim, but, we all kind of owe him a debt of gratitude for exploring the unexplored. And who knows, if it had worked, it would have been miraculous and a new option for patients who are with advanced cancer. It unfortunately didn't work, but
yes,
a lot of courage to do that.
Yeah, you're right, Len. I remember when he first came on and told us about that. It's been a couple of years now, but he told us then what he was going to try to do, and he said that he knew that it was very likely that he might die as a result of the treatment. But he was brave enough to even try that.
Right.
So it says a lot for the measure of the man.
Agreed.
Rick, do you know what was he Gleason? What his Gleason was and where his Mets were?
I just had it up. I just was. Rob Baniscus, by the way, was diagnosed at 44. Let me just go back to. Thibeaux. He was a Gleason 10.
I assume he had bone mets because of the transfusion, right?
Yeah. He was a Gleason 10. That's all I have here.
Yeah, the article says Gleason 10, indicating extremely high level abnormal cells and growth, a prostate nearly solid with cancer. The only bright side was no sign yet of metastatic disease.
They found the Mets in 2015. So he was diagnosed in 2014, and they found the Mets a year later in his abdominal lymph nodes with an enhanced MRI. So I'm just looking at his notes. He sent me at one point a history, and which I have here, and then I made my own notes underneath. Yep. Yeah, well, he certainly, I mean, he did have an RP, and he had seminal vesicle invasion and positive margins at the time of the RP. He also did GVAX, which was the vaccination that never really did much. So, okay. So let me do a roll call and see who would like to speak today. So, Jake, anything new for you to talk to us about?
No, I'm holding steady.
Holding steady. Okay. Carl, anything for you?
Yes.
Okay. Joe Blanchette, anything for you?
I need about 10 minutes. I got some news from NIH, and I just finished my last scan yesterday.
Okay. Len, anything you'd like to review?
I could give a 5-second PSA update.
We like that. Les, anything you'd like to review?
Just a quick question, I think. Yes.
Okay. Rich Jackson, anything for you to talk about today?
Still quiet on the Eastern Front.
Still quiet on the Eastern Front. That's what we like. We like quiet on the Eastern Front. Larry Fish.
Hi guys. No updates for me at the moment.
Okay. Sylvester, anything for you today?
No, thank you.
Wolfrieda, anything for you today?
Yeah, I can just get it over with. I'm still in remission, and my testosterone went up another 30 points.
Okay, well, hold on, because it's no good, because I have to pull it up, make notes and what have you. We'll come to you. Okay. Don't try and slip a fast one in there. It doesn't work.
Nice try, Paul.
Yeah, nice try, Paul.
I was trying to save time.
Well, you're doing a Jake on us. Come on. Okay. Bob Bordiger, anything? Well, yeah, you can tell us how you're coming along. So we definitely want to hear. Okay.
Sure.
Now, quick question: does anybody have any time constraints? Okay, then I'll just go through everybody, and we may still finish off quite quickly. So let's start with Carl. Carl.
Okay. All right. Just to share with everybody, I had my 65th birthday this past Saturday, and my wife had a surprise party for me, which she was very sneaky. And I had a little bit of an inkling, but I was really surprised. Went into a restaurant, and as I turned the corner into this big room, there were approximately 50 people standing and clapping for me. It's like, oh my God. It was just incredible feeling to have that.
So your birthday was
the 23rd.
Oh, okay. So you're exactly a week after me.
Oh.
Okay.
On to other business. Also, as those of you who have heard me speak before here, I had been struggling with the Social Security Administration for permanent disability, and it had been going on for about a year and a half, having been turned down twice initially, which I was told is normal. I had my appeal last Monday, and it was held in Newark, New Jersey, in front of a judge and small hearing room, a judge with a occupational expert, as well as a court reporter, myself, and the attorney representing me. So it was a quite short meeting. It lasted all of 10 minutes. When the judge looked at my medical records, and the attorney told me there were probably about 800 pages worth of documents that were submitted. And she immediately looked at the fact that I had my robotic surgery in November last year, and that it confirmed that there was metastasis. And she said, well, Mr. Foreman, I'm sorry you even had to come here, but it was clear to me that you should have been granted the decision. The attorney then added, he said, well, November was when he had his surgery, but he had his initial PET scan back in April, many months earlier, and that also showed some metastasis. And she turned to him and said, oh, okay, I accept that. So I guess within the next month or two, hopefully, so I'll get retroactive money. My Social Security benefit will gross up to my full retirement benefit at age 66 and 3 months, and that'll be backdated as well. So that was a nice accomplishment over there. And one of the interesting points that the attorney had made after the short meeting that we had in the hearing room, he said that there are many people who actually don't even show up for their hearing. The reason being is that a good majority of them have become homeless because they typically wait 2 years to get their hearing date, and they've had no income. So it's a horrible situation how so many people, and you don't show up, that's it. You don't get granted, even though you're not able to appear. So that was kind of a very difficult thing to hear, that there are so many people who just fall down the cracks from homelessness. And
so I can empathize with you. I went through the same thing, and the difference for me and for some of the guys that are applying, like Jim Ward comes to mind, and Ken, who aren't on the call today, that the importance of getting backdated to your diagnosis is that it starts to count off the amount of time before you're eligible for Medicare. Now, in your case, it doesn't make a difference because you passed 65 during the period, so you became eligible for Medicare. But if you're under 65, you have to be eligible. Your disability date has to be at least 28 months prior. So you may not, they only pay 12 months in arrears max. But if you can establish an earlier date that you were first diagnosed, and it's accepted, that's when the 28 months starts counting. So in my case, I think I only had to wait about 4 months to get onto Medicare. So it is usually very important, the date of diagnosis, with respect to, and then of course the other thing in your case is that your SSDI, well, no, it hasn't really started paying because you would have had to wait till 66. So that's a benefit to you as well. So you're getting your SSDI early, your Social Security.
Right.
So,
right.
Anyway, before we go on to any other medical issues regarding Carl, is there anybody that has any questions about the SSDI for Carl?
Carl, was it just a single judge that decided that, well, I'm sorry you had to come here, but you clearly qualify for SSDI? Or was it a panel?
No, it wasn't a panel. It was a single judge. And actually, the occupational expert who sat next to me, I had asked the attorney in advance. I said, what is that person here for? Well, that person's to determine whether you can do any job, whether you could be a delivery person for Amazon or some other full-time job. And he said, I said to him, well, would she ask me any questions? He said, absolutely not. The judge uses that person as a resource for any questions that the judge might have. But so that person wasn't asked any questions. I was prepared to talk about my entire journey, all of the side effects I've been experiencing, and the attorney who I found, by the way, if anybody were to need an attorney, there's a website called atticus.com, which was created by a Stanford law professor, and it was quite useful. They vet people, they don't just put them on there, and obviously it worked out nicely for me. But the judge had 2 computer screens on her desk, and as she was talking to me, she was looking on her screens at my medical records, and she only had like 2 minor questions to ask me, and the attorney pretty much, when he prepared me, and he also apologized after the fact, he said, you had the best scenario, and I prepared you for the worst. So I apologize for putting you through that aggravation, but I said, well, look, hey, that's fine. I was prepared. But I didn't feel totally absolved, because by them bringing up the fact that I showed some metastasis back in April, and that kind of reminded me, boy, I didn't know that I really had prostate cancer until I had the biopsy, and that was in June. So this was April, 2 months before the biopsy, that they showed mets in the spine, and even now that hasn't really been focused on per se. I was always told I had metastatic to the pelvic bone. And the last scan that I had, which was the axillum, and there was like no clear resolution to say, well, we can't tell whether it's bones metastases that have healed or otherwise. So I'm just going to take it as a positive thing overall and not dwell on that, because even in April, my PSA, although it was accelerating, and it accelerated to the day before the biopsy, I found out my PSA had accelerated from 6 weeks earlier, from 5.7 to 20 in just 6 weeks. So at that time, my PSA was already starting to rise. But anyway.
Any other medical updates you'd like to talk about? Anything other than the SSDI, Carl?
Somewhat related is that the Princeton Medical Center had its 100th anniversary celebration on Sunday, and it was an open forum. They had all kinds of events and demonstrations. And the one demonstration they had was they had the Da Vinci robotic machine. It's like, okay, well, the only thing I remember when I had my robotic surgery was that I had a 30-second glimpse of the machine, which almost looked like something with claws, and then I went right to sleep. So they actually demonstrated how a doctor looks into the screen and how they manipulate the machine. So I found that fascinating. And they also had a sample on the screen of a prostatectomy that you can do, and I didn't want to do it, but the person from the Da Vinci company actually did a sample robotic prostatectomy, and he messed it up so much it showed on the screen critical error, so he probably killed the patient with that. But that was I guess somewhat medical related, so that was it.
Carl, I put atticus.com in the chat box. I hope I spelled it right. I assume that's based on To Kill a Mockingbird.
Yes.
Atticus Finch. Yeah.
Yep, that's it. Yep.
Okay. And I wanted to make a comment to you. Since you're getting disability, make sure you be careful about making any kind of money. Because yes. when I got disability originally, and I was doing a little bit of work for my wife, record keeping and whatever, for a daycare business, and I reported it so I could get Social Security credits. And I got a nasty note saying you can't do that when you're on disability. So
Wow.
just be careful. I mean, I think once you're on once you reach 66 number of months, you can make any amount of money you want.
Right.
But when you're on disability, you have to be very careful.
Yeah, you do. You don't. I mean, you can work. They just reduce your disability accordingly. So make sure you look at the trade-off before you report anything, because you may finish up having to give something back.
Right.
So,
Yeah, I haven't worked for the past year and a half. The only thing I am getting are renewal commissions from Medicare policies I sold several years ago, which I explained to them.
Yeah, but which is fine, but it may reduce your Social Security.
No, they said no, because
No?
it wasn't an active participation. It's just renewals from past businesses. There was nothing that I needed to do currently. I'm not working in the field, haven't done anything other than it being a renewal.
I thought it had to do with income, but I may be wrong. So just check, just double check.
Yeah, I did. No, I checked. Yeah.
Okay. And I just want to tell you one other thing. I've been fortunate enough to have a couple of surprise parties, but one of them was like yours, and they walked me into a room, and there was probably 40 or 50 people there. And not only was I surprised, but they all had Groucho masks on, so I didn't even recognize who any of them were. So everybody yelled, "Surprise!" I didn't even know who was there. So
Well, happy birthday to both of you. Happy birthday, Rick, and happy birthday, Carl.
Thank you.
You're not going to sing for him, Len?
Not necessary.
I hate that song.
Which song?
The birthday
Happy
song.
birthday.
Oh, the birthday song.
So
Joel?
annoying.
Hey, Joel, are you with us? It looks like he may have. Oh, yes.
Yes, I am.
Okay.
Are you ready for me?
Wow, you have the stage, man.
Okay, news from NIH. You guys probably already know this already, but NIH, starting in January 2020, will be giving a theranostics clinical trial, offering that up. And for people who qualify, and I don't know what the protocol is, it's not on the clinicaltrials.gov site yet. I don't know what the protocol will be, but they already have a couple doctors picked to head the study, and they'll be doing that. Plus, they'll be putting 2 or 3 more DCF PYL clinical trials for the PSMA PET scan. That'll be done in partnership with Progenics Pharmaceuticals that also manufacture that tracer. And right now, the tracer is being manufactured by NIH directly in their cyclotron. But in the future, with the newer clinical trials with different protocols and Len and I's clinical trial, they'll be using that company in partnership with them. I think Oliver Sartor said that this week sometime or last week, that UCSF and UCLA had applied for the PSMA approval from the FDA. They hadn't heard yet, but they expected to hear soon. And that once it gets approved, that scan will be available all around the country pretty quickly. So anyway,
Hold on 1 second, Joe. Let me ask you a question on that. So when you say theranostics, are you talking about like a lutetium trial? Is that what you have in mind?
Yes, exactly. Lutetium 177, PSMA 167, like Michael Hoffman in Australia is doing.
Did we freeze up or is it just me?
I'm still on, but Rick seems to be frozen.
Yeah,
It's a Rick thing.
it's a Rick thing. Okay. So Theranostics, Joel, is that the name of the company that makes the lutetium?
No. That's if you take the PSMA PET scan and you scan a person's body and they find some PSMA or prostate cancer due to the PSMA, the prostate cancer cells emitting PSMA protein on the surface. They then give you lutetium, and then they scan you again. And the lutetium kills goes to the prostate cancer cell, the same cell that the scans picked up, and they kill the cancer. And then they take another scan again and see if there's any cancer left. If there is, they can do it 2 and 3 times. And if it ever comes back later on, they can do it again. So the whole, I mean, this might take 10, 20 years to get to, but what they're really trying to do with this is they're trying to give it to you up front so you don't have to do a biopsy and go through radiation and all the other drugs, because they feel that eventually, if this is successful to what they are imagining today, that they can say, oh, you have a high PSA, we'll give you this isotope, this tracer, will kill your cancer, then we'll monitor you. And so, but you know, we're far away from that, and many clinical trials away from that. But that's the intent eventually. That's what Michael Hoffman's intent is in Australia.
Yeah, I lost you a little bit there, unfortunately. I'm sorry, my connection faded for a while and came back. But so what about your own personal situation?
Well, I have a very unique situation, and I still don't know the answer. It started out by NIH saying you need to go get a CT scan before you get into the trial. So I did. So I went to get a CT scan. The radiologist said, "Hey, you have you have something wrong with your iliac bone. I recommend that you get a bone scan." My primary care doctor refused to give me one, so I brought the scan to NIH, and the CT scan at NIH. Says, "Well, because you have a possibility of cancer in the bone, we're not going to give you the multi-parametric MRI that we promised you. But based on our protocol, we now have to give you a sodium fluoride scan and a FDG scan, but we'll still give you the PSMA." So on Thursday of last week, I went and they gave me the sodium fluoride scan. The radiologist said, "Well, we don't see any bone mets at all except for that one spot on the iliac bone, and so we recommend that we can't tell if it's cancer or not, prostate cancer or not, so we recommend a biopsy." So then on Friday, I took the PSMA PET scan. PSMA said, "You have no soft tissue lesion, none whatsoever that we can see, but we can see there's something wrong in the iliac bone. We recommend a biopsy." But then yesterday, I took another scan. I took the FDG scan, the same story. They can't prove anything that I have prostate cancer, but the PSMA and the FDG tracer gathered around the iliac bone. However, they're saying that it's possibly a disease. It was founded in England. It happens to people with English descent, which I am, and the term is so new to me that I drew a blank right now, but I'll get to it. And it's Paget's disease, Paget''S, Paget's disease. That was the doctor who found out this. And usually in the old days, it was people had deformed foreheads, deformed bones in the body that showed on the outside of the body. But it can happen to pelvic bones. It can happen to other bones in the body also. So right now they're saying, we think you might have this Paget's disease. So I talked to the doctor. Dr. Lynn may know her. She was very good, extremely informative, and I'm going to be in touch with her every day for the next 2-3 weeks probably. Talked to the doctor today, Dr. Mina, and Esther Mina, and she said, you know, she said, I pulled in 4 other doctors from NIH and showed them your results. And a couple of them said that you don't have prostate cancer, you do have Paget's disease. And a couple others say, including myself, she said, I think you have prostate cancer. But the only way we're going to be able to tell is do a biopsy. And now, so she left it up to me. She said, you want to do a biopsy at NIH? Because all we're going to do is a conventional biopsy. But Johns Hopkins is more sophisticated biopsy method, so which my GU oncologist Antonarakis already told me about. So I'm going to leave it up to Antonarakis whether I get the biopsy from NIH or whether I get a biopsy at Johns Hopkins.
Are they talking about a biopsy of your prostate or of the iliac bone?
No, I'm sorry, I don't have a prostate anymore. I haven't had a prostate in the last 8 years, over 8 years.
So they want to sample the iliac.
Exactly, because they don't know themselves if there's cancer there or not. I mean, after 4 scans, the radiologist or 4 other doctors could not tell me if I have cancer or not. Now, I could have prostate cancer in soft tissue someplace that is not big enough for the PSMA PET scan to catch. That's a possibility. My last reading was 0.9. So that's a possibility. But it's all, I think that I have prostate cancer in the iliac bone, and so does Dr. Nina. But you know, they can't write a report up until they know for sure. So that's why they want a biopsy.
I'm surprised they asked you to do an FDG scan, because that's, correct me if I'm wrong, Len and Rick, but isn't that kind of old hat? It's kind of obsolete technology, I believe.
The metabolic scan that shows where the cancer is very active, and in my case, it shows
that's the one where you drink the glucose, right?
Yeah, exactly.
Yeah,
and,
yeah, that's old hat. All the newer PET scans are much better than that one.
I understand, but it was part of the protocol of the clinical trial that Len and I we couldn't get away from it because they're tied by the protocol.
Right.
So that's where I am. I don't know if I have prostate cancer in the iliac bone, whether or not it's, and also Paget's disease produces PSMA, which makes it more complicated.
Oh my gosh. Huh.
I never heard of Paget's disease until yesterday. I mean, I've been studying prostate cancer for 9 years now, and I've never heard of Paget's disease. Never.
Well, I mean, I don't think Paget's disease has much to do with prostate cancer, but I'll look at it later. I've definitely heard of it, but I don't know much about it. Len, do you know anything about Paget's disease?
Not much, no. I always thought it was a bone condition found mostly in very young children.
All right, yeah.
The doctor said, I asked the doctor, of the people, there's 210 guys like Glenn and I who have gone through this PSMA PET scan clinical trial so far. And I said, how many guys with biochemical recurrence have you had that had Bowen's disease? She says 30. I says, of those 30 guys, how many had Paget's disease? She said 2. I said, well, what were the results? She said, well, one guy had a bone lesion on his on ribs, and he had Paget's disease. We biopsied him, and he did not have prostate cancer. The other guy had a lymph node that was positive with prostate cancer, and a rib that was diagnosed with Paget's disease, and it was biopsied, and he did not have prostate cancer. So that's where I am. I don't know if I'm number 3 guy, if I'm going to follow the same pattern, or if I'm going to have prostate cancer in the iliac bone.
Well, it's certainly an interesting story. Questions, anybody?
So Joel, are you scheduled for a bone biopsy at NIH, or did you say Johns Hopkins.
Well, tomorrow I got to contact Dr. Antonarakis through my chart at Johns Hopkins and ask him to make the decision of whether he wants, because he talked to me when I saw him back on the 1st of October that NIH has a new way of scanning bone. And so his new way of scanning bone may be better than the old conventional NIH bone scan. And so that's what I want to find out from him and let him make the decision as to what he wants. And because NIH is willing to do it. As a matter of fact, she even put in for approval today after she talked to me. She said, even if you don't want to do it, that's fine, we'll just cancel it.
Yeah, just to correct you, I think you said that NIH has a new way of scanning bone. I think you meant to say Johns Hopkins has a new way of scanning bone. Is that right?
That is right, Rick. I'm glad you caught that.
Yeah. Just in case anybody listens on the recording. Well, certainly keep us posted. Len, do you just want to give a little bit of information to Joel and anybody else who listens now or later on the actual process of the bone biopsy?
Yeah, sure. First of all, they give you an option of having just local anesthesia or general or a twilight, something in between. In my case, I opted originally for just local anesthesia, which is lidocaine. And after they started banging away at my hip to get through the bone with a mallet and hammer, I said to them, I'm starting to feel some pain. I think you better start that slow fentanyl drip. So they did give me just a very little bit of fentanyl. I was still awake through the whole thing. And they move you in and out of a type of scanning tunnel. And when you're in the tunnel, there's a little fluoroscope set above where they can see exactly, what they're doing and where they're banging away. And then they take it out, they put you back in, and they keep banging away, and they take it out again. So the whole thing took about maybe 15, 20 minutes. And there was no post-op pain whatsoever. I didn't even take Advil afterwards. I mean, even after the fentanyl wore off, I didn't need any medication at all.
Right. Well, that's good. Were you on your stomach when that was done, or on your back?
On my back.
Okay. The doctor said that she would be in the room with the surgeon because she wanted to make sure that during the biopsy that the surgeon was operating on the correct bone. There was no mistake.
Yeah. Yeah, I mean, I could see on the fluoroscope the outline of my pelvic bone. I could see the little whatever they call it, the little wedge that they bang into your hip. They do that just to break through the bone, and then they use the hole that's created there to thread the biopsy needle through to take the actual biopsy sample.
So
in my case, they took 2 core samples. One was positive, one negative. Mine was definitely prostate cancer. They said stained heavily for PSMA and PAP, which is prostatic acid phosphatase.
Okay. They're taking samples of the bone marrow, correct?
Well, I presume so. Yeah, I think that's where prostate cancer lodges itself, in the marrow.
Right, and the marrow is what's responsible to make your blood. And
correct.
How do they prevent the bone marrow from escaping your bone that they've now banged and cracked open to the rest of your body? How do they prevent that from happening?
Well, bone marrow is it's not liquid, it doesn't leak out like a liquid would.
Okay.
It's tissue. It's living tissue, but it stays in place.
Okay. And how do they patch you up after they're finished?
A Band-Aid, believe it or not, that was it.
They didn't have to cut into your skin very much?
No, not very much at all. I mean, yeah, there was first a little scalpel incision, just to get through the little bit. I don't have much much tissue or fat underneath my skin between that and my hip bone. So for me, they didn't have to go very far.
Right. Okay. And did they send I got the impression that they could send, if there was enough sample, they could send half the sample or part of the sample to your medical oncologist or whoever your doctor is. Did they do that?
They did not, because they told me they were going to do genetic mutation sequencing on the sample they took. So I figured if they're going to do it, it's not going to cost me anything. Why should I have it sent to my oncologist?
Right.
But I'm sure I could do that if, let's say if I still haven't gotten the sequence analysis done, but with the mutation analysis. But I suppose I could, as a second opinion, have that done, or I'd probably have to pay for it.
Dr. Mina told me that, she would look favorably towards if my medical oncologist requested it, that she would look favorably upon sharing the sample. Also, I asked her out of the clear blue, I don't know why that occurred to me, on Friday of the PSMA scan, they took a second blood draw. And about an hour or two later, I asked Dr. Mina, I says, do you guys do any CTC monitoring? And she says, yeah, we do. She says, let me call Yolanda. She calls Yolanda, and Yolanda says, yeah, we just did one on him this morning. I said, well, can I see that CTC report? And she says, no, it won't be part of your first reports that we're going to report on your scans to the doctor. But if the doctor requests, we can send the circulating tumor cell report to the doctor. So that's another thing they didn't tell me about. I didn't know I was going to get that. I just happened to luck out and ask for it. And they said, yeah, we do have it. We do that for our own internal studies.
Well, that's interesting. I was not aware of that, and I didn't even think to ask about CTCs.
Yeah, well, I didn't, nobody mentioned it to me. I just happened to think that maybe my medical oncologist would be interested in it.
Yeah, I'm definitely going to ask now that you mention it.
Okay, great.
Thank you.
Well, the importance is that if you do have CTC, then you're probably going to have free DNA, which can be analyzed. And also, if you've got the bone marrow sample, that could be sequenced. But in your case, Joel, it might be a little early to burn your somatic test with your Medicare.
Yeah, well, it's already been done. We talked about that the last couple of times I was on. Dr. Antonarakis already ordered a Foundation One medicine, 326 or 86 genes test, and of course I haven't had any ADT or any other treatments other than prostatectomy. So, as you said, the fact that hasn't happened, my cancer probably hasn't mutated too much. But
it's just a shame, and he may be able to get him to do. If you've got a newer sample that could be used, he may be able to get him to work on that. But
well, you were just discussing in something I read that you wrote that you were at the Foundation Medicine this past week or so, advocating for a cheaper scan.
Repeat scan. We're trying to get them to incorporate a program so that if you go back and need additional analysis, not a scan analysis, that you'll be able to do that. But it's going to be it's probably going to be a good year before they do that. But that's what we're asking for.
Right.
Larry. So Len or Joel, when you get a biopsy and they have some tissue material, don't they also make a number of slides? Or is that not true? So that when or if you change to another hospital who wants to do their own analysis, like a Dana-Farber or John Hopkins, and they request some of those slides and they send some of those slides and they have them if they did that extra tissue.
That's absolutely correct. They also
Yep,
slide.
I can do that.
Go ahead, Len.
No, I was just confirming what you said. They when they take the sample, they have to slice the tissue from the sample using a microtome. They lay it out on a slide, they stain it, and then they look at it under a microscope, and that's how they can, determine the morphology and, just like any other biopsy, even when you're first diagnosed with prostate cancer, they go through the same thing. It's embedded in, I forget the exact acronym, but it's like paraffin embedded tissue sample. And yeah, they can send slides.
Len, formalin? Is it formalin?
Formalin fixed, paraffin embedded, something like that. I don't remember the exact.
To answer your question, when I had my biopsy done in Bangkok, I got the slides and then I took them with me to Memorial Sloan Kettering, where I had my prostatectomy. So yes, you can transfer them from one hospital to another. And what happened was in Bangkok, I was diagnosed as 3-4, and then Memorial Sloan Kettering changed it to 4-3 when they analyzed it. And then after the prostatectomy, I was diagnosed as 4-4.
Yeah, I just took a look. It's FFPE, formalin fixed, paraffin embedded. That's typical biopsy preparation.
Thank you guys for that.
Sure.
Okay, well, let's keep moving along because we've still got 3 or 4 guys to visit with. I just want to make sure we have enough time. Len, it looks like you're the next one up as well. So tell us about your most recent PSA.
Yeah, so it had been 1 month since my last one. Dr. O had previously had me on 3-month PSA checks, but I guess once I was diagnosed with bone mets, he decided he wanted it monitored monthly. So last month I was at 0.42. This month it was 0.23. So moving in the right direction. Darolutamide still working, and I'm still tolerating it very well. I also got an injection of Xgeva.
Good.
Yeah.
Okay. I thought he was going to give you Prolia, so you didn't have to go so often.
Yeah, that's what I thought too. There was some miscommunication between Dr. O and the nurse practitioner who was giving me the injection. So what they did, since Xgeva is identical to Prolia except it's twice the dose, they checked with their pharmacy and they said, yeah, you can just dump out half of the vial, if you want. So they had gotten approval for Xgeva and not Prolia. They probably could have gotten approval to give me Prolia, but if for some reason it was denied, then I'd be paying for Prolia. So basically they injected me with half a vial of Xgeva, equivalent to Prolia.
Okay.
Yeah.
And how often are you going to do that, Len?
So as you know, Prolia is like a 6-month thing. So, I'll be in Florida soon, and I'll be back in early May, and that's when it'll be time for my next injection. And I may get the full Xgeva dose at that time because I told them I first wanted to start off with a low dose because I wanted to make sure. I've heard guys talking about getting bone pain and some other unpleasant side effects. So I figured let me first start on a lower dose, make sure I'm tolerating that, and then next time around I'll go with the full Xgeva dose. And so I didn't have any problems with so far.
Okay.
That was a week ago.
Okay. Okay. Anyone else want to talk about Xgeva, Prolia, which are both denosumab or Zometa, or I think there's another new one I read about that's coming. I don't know. But anyone else want to discuss these bone meds?
Yes, I've been on Xgeva for some number of months. I started out every 30 days I think for the first 2 or 3 months, and then it went to every 6 weeks for another 2 to 3 months, and then most recently, the last shot I had, they said we'll do it in 3 months. So I continue on those injections of Xgeva.
Okay.
Did you guys who are taking Xgeva, did you do like bone density or some kind of check before you decided to make a decision? Or do they, like the doctor I saw at Dana-Farber for consultation said, maybe you should go for a bone density and check. There may not be, even though I had a big metastasis to my hip, he said, well, you should go and do bone density. If your bone density is good, unlikely for fractures, why start Xgeva now? That was just what happened to me.
Because it's the protocol and the tests have been done and they show that you see fewer bone-related incidents down the road. Now, if you have metastasis. In my own case, where I probably had micrometastasis, they gave it to me because my bone density was so poor. But that's a different situation. I mean, these guys should not be confounding bone density issues. In my opinion, I would be objecting if they were relying on bone density measurements when I had metastatic disease.
Right.
Because, it's your choice. You don't have to have it if you don't want it, but the protocol is you should get it.
Yeah. I know they kind of left it up to me with a suggestion that maybe to hold off, and that's what's happened.
If it were me, I'd get it, because the way it's been explained to me, it really deters the cancer from spreading. It makes it makes it more difficult for the prostate cancer cells to grasp the bone and to spread into the bone.
That makes it sound like a very significant reason, in addition to the fragility of the bone. I think I'm going to have to discuss that with my doctor next time I see her.
Yeah, I mean,
it makes sense to me.
I mean, the guy that explained it to me, this is going back some time, who was an endocrinologist, explained that it does two things. It makes the bone denser. It may make it more brittle in the process, but it does make it denser, and it makes it slick so that it's harder for the cancer cells to get a grasp to settle in. Anybody else on that, Len or Carl or anyone else who's had one of these compounds?
Well, I've been on Zometa for 7 years.
Yep.
And my understanding is that it has to do with as you said, Rick, but it also has to do with osteoclasts and osteoblasts, the turnover of the bone.
Yep.
And that blocks the ability of cancer to grasp hold. But I have a question on this on the group, and maybe somebody knows. We know that Xgeva, Zometa, all those drugs can increase your susceptibility to osteonecrosis of the jaw. But does anybody know of it ever affecting your teeth? because I've had several teeth. I mean, I've had bad teeth all my life with lots of fillings and everything, but just lately I've had like 3 teeth collapse. You know, the tooth just kind of broke, came apart.
Mm.
And I haven't been to the dentist yet, but
I have
has
heard.
anybody ever heard of Zometa having that effect, or is it just totally
Yes.
unrelated?
Yeah. No, I've heard of Zometa. I've heard of people on Zometa having that issue. I can't talk about cause and effect. That's something you'd have to ask your doc. But you've been on it for so long, and you see what happens is it makes your bone, teeth are bone, and it makes the bone denser and it makes it more brittle. So on the one hand, it makes it harder for the cancer to spread. And so when it doesn't spread, it doesn't eat into the bone. And so you don't have the holes and you have more, and so you don't get more fractures. At the same time, it makes it more brittle so that if there's trauma, it could fracture. And, you know, as I've said to you for a long time, if it were me, I would have been taking a break. I would have gone to a much shorter, a much longer cycle, and I would have taken a break for a while because the half-life is so huge, and they could be related.
I've never heard of it affecting your teeth though. Is it, and you
Well,
say you never heard that?
I'm saying to you, I've heard of several guys who had teeth issues. Frank did. That's one person who comes to mind right away.
Frank Kelly?
Yep.
And also, Jake, I mean, keep in mind your teeth are anchored in your jawbone.
Right.
So, you know, people who have ONJ do lose some teeth. So you should certainly get to your dentist, make sure that it's just a tooth issue and not a bone issue.
Just
Yeah.
But, you know, Rick, I was going to say there was it's very confusing. There was a discussion between Alicia Morgans and Fred Saad, I think his name is.
Yep.
So they were discussing a study that Fred Saad did that supposedly showed that you know, taking these bone strengthening agents like Xgeva were it was a good thing and it was prolonging life. But then I found another study done around the same time where 2 guys were arguing against the weaknesses of Fred Saad's study, and he was saying that they don't really help much. So the experts disagree on just how much these bone strengthening agents are useful or not.
Okay.
just
All right. Well, I want to keep moving. We can come back to this if we have time at the end, but I've still got 3 guys to cover, and we've got about 35 minutes. So I just want to make sure we get to everybody. Les, I think you wanted to say something just now anyway, and you also wanted some time. So push the 2 together.
Okay, I was just wondering, I've been on Prolia for about 6 years. So, what the things that you were saying about that type of drug, does that apply to Prolia as well?
Yes, because Prolia is the same as Xgeva. It's just a different dosage. It's a lower dosage. So you're getting a lot less of it, but it still stays in your body a lot longer. But if you're getting regular doses of Prolia, it's, you know, it probably isn't going to have as big an impact as if you were getting regular doses of Xgeva. But again, we don't give medical advice. I'm just using common sense because of the dosage. Len, do you want to comment on that? Because you've looked at Xgeva, Prolia.
Yeah, no, I have nothing to add to what you said, Rick. I agree with you.
Okay, the other issue, I didn't know if Len, if you want to say anything about this streaming issue for the Prostate Cancer Research Institute
Yeah, I did want to tell you, Les, that I did get the link from PCRI to begin the streaming, and they gave me a password, as you said they would, and they said I have basically unlimited access to the site to stream any of the content of the PCRI conference. So basically, what I did with Les was I just sent him my name and my email address, which so that he could copy and paste it into an email address that was sent off to somebody at PCRI, and then PCRI contacted me directly and said, here you go, here's your access to streaming, unlimited streaming of the PCRI conference with a password.
Now, what is the procedure if we to share that this year? Is that just you, or do you have the ability to share it?
Everyone who's interested would have to send Les their name and their email address. Les can aggregate them or send them one at a time, however he chooses to handle it, and send them off to PCRI, and then PCRI will send Sylvester or Rick or Jake his own password in an email.
So
what are they streaming, Len?
Instead of using a DVD to view the PCRI conference proceedings, gotcha. You're just streaming the content. There's no DVD. We don't need to pass that around, keep track of who has it. We don't have to worry about FedEx expenses passing it around. It's all free, or at least thanks to the Us2 group, I guess, by Les Sheldrop.
Yeah, I have some background info on that. I wrote an email to PCRI about 2 weeks ago asking for a new set of DVDs, and I had bought them for the last 4 years, and I used some of them to present to my prostate cancer support group. So about a week later, I had heard from them, but they called me and said, "Hey, we're changing ways we're doing things. You have our videos from 2014 to 2018 on your FTP server, and we need you to take those down because we're going to start selling our streaming videos." I says, "Okay." But she says, because you did so much work on those videos, we're going to give them to you for free, or anybody in your group who wants them for free for a full year to start with. So what I had done is I had taken all the CDs, and as you know, a CD has everything on it. It has 3, 4 speakers on each, either a question and answer period or a lecture from the speaker. And I had separated them all into individual lessons, like 1-hour lessons or so, depending how long they were. And I put them on the FTP server so anybody in the world could pick them up and download them and view them on their own computer. So I had done that 3 years ago, and I kept on updating it every year. So now those have been taken down, and so PCRI can now, how much do they charge for it, do you know? The streaming service?
The streaming service is $75, but we have paid for that, and we have gotten approval for access to anyone on this and can call to get that code. That has already been cleared, and Len was an example of he tried it and it worked for him. So all you'd have to do for anybody on this call or this system, just send me an email, your name and email, and I will collect them and send them in to PCRI, and they'll send you a link, and you set up your own password. The only thing is you must hang on to that link and your password, because I will not have it.
Okay. So Les, what we will do, both Peter and I will make sure Peter is aware, is in our reminders over the next couple of weeks, and then we can do it again sometime next year. We will tell people that the PCRI streaming is available, and if it's okay by you, we will ask people to send their email, their request to you by email in order to facilitate it. Does that work for you?
Yes, that'll be fine. But I set up an email address specifically for this effort. Just ancanpc@gmail.com.
ancanpc@gmail.com. Perfect. Okay, I've got it, and we'll tell them to send it to there, and that's great. Okay.
Do you
Very
also
good.
can you also attach somehow, if that can be done, the different presentations? I sent you and Len the list of, I think it's 14 presentations, so that people can see what the content is.
Yeah, I can forward that to Rick, and he can forward it on to everybody.
Yeah. Len will forward that to me, and forward it to me and to Peter when you can, and then we'll distribute. I don't want to take any more time on this call, but I'll work with Len and with you, Les, and thank you very much. We're much appreciative, and not only are we appreciative, we'll make sure that people know that this was through you and all your work that you've done, and through your own group. Where is your Us Two group? Rock Island. What's your Us Two group?
It's called the Greater Quad Cities Us Two.
Got it. Okay. Fine. Thank you very much. All right. Let's. Was there anything else, Les? Or
no, that was it.
Okay. Excellent. So we still going to go to Paul Frieda and then Bob Bordiga. Paul Frieda. Are you there? No, he's taking a break. Mr. Frieda, are you there? Yeah, he's stepped away. Okay. Then we'll go to Bob, and then we'll come back to Paul Frieda. Bob, how are you doing in your recovery?
Well, it's been 4 weeks since my surgery, and I was doing pretty good for a while, and then I had a little bit of a setback because I probably overexerted myself. I started walking, and I walked about 2.5 miles one day, and then that night and the next day, I was feeling not as good, and I've been coming back from that. I was cleared to do some. I saw a physical therapist this past Wednesday, and he said I'm doing a good job with my recovery of my continence, and he gave me some exercises to do where I do sustained Kegels instead of just the short burst Kegels, and so I've been doing that, and I'm about one to two pads. One pad a day, or one every 2 days at this point. So I'm doing pretty good, I think. I have trouble sitting for long periods of time, and I could, and so I'm just driving short distances right now. And I was hoping I would be a little further along, but I've learned that I got to be patient, and that. My mind is in one place, my body's in another one, and I got to listen to the body. So that's kind of what I'm dealing with in terms of my health from the recovery of the surgery. I've got appointments next week with my urologist and also with radiation oncologist. Some consults about next steps and all. I'm getting a PSA tomorrow. I had one already, but it doesn't really count because my testosterone was just starting to come back up from Lupron. This one tomorrow might count. I don't know. But if it does, then I'm going to be getting the ultra-sensitive PSAs, which I have to pay for myself, but it's not that expensive. And I'm going to particularly want to do one about 3 months out because of this study at Johns Hopkins with people in my category, which is Gleason over 8, mine's a 9, and lymph node involvement. I had a small amount in one lymph node. For those folks, the study said that if the ultrasensitive shows that I'm less than 0.03 3 months out, that the likelihood of recurrence within 10 years, or likelihood of a PSA rise within 10 years, goes down to 14%. But if it's greater than 0.03, then it's up at 78%. So I thought that might be useful to know before I start hormone therapy.
Yeah, but that's helpful. How you said that you had some effects from too much exercise. What was the impact? Was it pain?
I got a really sharp pain, like worse than I felt any time after surgery, or in my right side. I believe that's where the nerve was cut, right like near my abdomen.
Okay.
And then it subsided, and then I was taking the pain medication. I got myself off of that. But now I also feel some discomfort in my stomach area. I'm not sure what that is. It may have to do with when I'm sitting and bending my body over there in that position. But I'm gonna check in with the doctor on it on Monday when I see him and see what he has to say about that.
And how long is it since October? It's about a month. October.
It's 4 weeks, exactly 4 weeks since surgery.
Yeah. Well, take it easy, especially on, they say don't strain those abs for a good 6 weeks. That's the rule of thumb, even if you're in shape. So don't, take it easy on those abs. It is a big surgery. And I think a lot of people don't appreciate the size, the amount of surgery that it involves, that the radical prostatectomy involves. But it is a
I mean, I wasn't feeling it when I was walking. I just felt it afterwards. Weird.
Yeah.
But anyway, I think that just timing-wise, I think that had something to do with it. So. I was going to say one other thing.
Yes.
We were talking in the beginning of the conversation about Thibeaux passing, and a week. This is not an equivalent, but it reminded me. A week before my surgery, one of our 2 cats got sick, and we brought him in, and he got cancer. He got diagnosed with lymphoma, and it was pretty serious. And we put him through a course of chemotherapy, and he was responding at first, and then not so much anymore. And we came to the decision that it was time for him to take the final sleep, the long one for which you don't wake up. And so we brought him into the hospital. I actually got in the car for half an hour each way to go with my wife to be there. And it was very peaceful, and it was very sad, and we were crying and all that kind of stuff. And we saw him off. He's 13 years old. But this kind of thing, with going along with what I've been going through, it's really made me feel a lot more, or think a lot more about my own mortality. And I find myself having much deeper conversations with some of my family members when I do talk to them than I have had before. It's just kind of changing my perspective about things in some kind of subtle way. I can't explain it that much more beyond that, but I just wanted to report that also.
Well, we'd love you to open this conversation up for us on Speaking Freely. So, Mr. Jackson, you still with us? When's that next Speaking Freely call in December?
Well, it's the third Thursday, so let's see if we can figure out what day that might be. Come on up.
19th.
Sounds good.
And how do you like the idea of the discussion that Bob just raised?
That's a discussion that each and every one of us has to have, at least with the person that lives in the mirror at one time or another. There's no real good time to have it. Not sure the week before Christmas would be ideal.
That's the day before my birthday also, so.
Could be a bit of a conflict in interest there, but it's definitely something I'd like to get on the schedule.
Well, as the lead moderator for Speaking Freely, we will allow you to decide when you want to use that as a topic. It doesn't have to be on the 19th of December, but whenever it is, we sure would like Bob to be there.
Let's see. The credit card bills should start showing up first or second week of January, so January might be an excellent time to have this one.
All right, let me put it in my calendar, okay?
Okay.
That would be the 16th of January.
16th of January. We're going for a more cheerful topic, gents, on the 19th of December. From what I hear from.
Well, this is not uncheerful. I mean, I don't think about it as a bad thing. I mean, I'm at peace with whatever happens one way or the other, and I'm 70, so I've had a nice long life. I'm not 48,
right.
So
right.
I'm okay with it.
It's not that it's not cheerful. I think if we actually published it very much, there might be a bit of a drop off in attendance for that particular time frame.
Are you calling me a killjoy?
It's an important discussion, but it's more, it's like a business location.
Yeah.
This one's timing.
Right. Right.
But January, I think, would be an excellent time.
That reminds me of my career as a production manager on movies when I would have department heads in for budget meetings. And they were not so happy sometimes with the kind of conversations we would have at those things. So I'm used to it. I mean, I was cast in the part of the bad guy, took some money many a time. And, somebody's got to do it.
Yeah. All right.
And I was good at it, too.
Well, you better be there. Ken Anderson, welcome. I'm sorry I didn't welcome you earlier. We started this session, Ken, with the news that we lost Thibeaux on Sunday night, and we welcome any tributes to him. And I just wondered if there was anything you would like to say about Thibeaux.
No, I really didn't know Thibeaux. He was in on the calls of just a few times when I was around. So, not so much. Sorry I got in late, but I was with family here in South Carolina.
That's okay. Are you a great uncle?
I am a great uncle. The little guy's name is Owen Vincent Noonan. Yep.
Okay. Well, congratulations to you. Everybody healthy?
Everyone's good. Yeah.
Good. Was there anything that you wanted to talk about tonight?
Nope. Just hanging. No, nothing to talk about. I'm good.
Okay. Well, hopefully Mr. Frieda is back with us. Are you back with us, Paul?
Yeah, I'm here.
Okay. Well, we called you before, but we couldn't find you. But now you're back.
I got called away by my daughter.
Yes, you're up.
Oh, okay. It was nothing. 30 seconds. My blood test shows I'm still in remission, and my testosterone went up 30 points again as it has been doing for the last number of tests. So now I'm at 125, something like that.
Are you feeling better from having more testosterone? Are you noticing a difference at all, Paul?
No, I don't.
Mm-hmm. Mm-hmm.
Can I ask a question?
Maybe it'll kick in next time or something. I don't know.
Sure, please.
What?
Yeah, you mentioned your testosterone is going up. Is that because you had been on hormone therapy and now we're off of it and it's starting to rise again? Because that's my situation.
Exactly. I stopped. I got my last injection August of last year. So so I'm a little more than a year on vacation. So
Wow.
hoping it'll
Taking
stay
that
there.
long to come up even only to 125?
Yeah, it's coming up very slowly. At first, it didn't move at all. Then it's been going up about 30 points every 6 weeks or so, and it's been pretty consistent. So,
Oh, good to know.
yeah,
You're still undetectable, which is the important thing, right?
absolutely. That's that's the golden number. I'm happy to see that less than 0.1. So,
Does your doctor consider the PSA test to be meaningful, even though your testosterone is less than 150?
he hasn't said anything about that. I don't know. It would seem to me that it's the higher the testosterone, the more likely it is, the cancer is going to come back. The PSA is going to. So it's good that it's holding as it's rising.
Yeah, because I was told that the PSA test is not valid unless you're over 150.
I'm not sure I understood your question.
Hold on a minute, one at a time. Bob, you give your comment, and then Paul, you respond. Bob?
Oh, I was only saying that I was told by my urologist that until my testosterone level was above 150, that the PSA test was not meaningful. That's what he said.
Why is that? Do you know why that would be? I mean,
I don't know, but that's what he said. I'm going to meet with him next week.
When you're on hormone therapy, your testosterone is less than 20, and the PSA test is valid, isn't it?
Well, it is valid, but I think we're talking a little apples and oranges here. The situation with Bob is that he had a radical prostatectomy, and that was the initial part of the initial treatment, as was doing some ADT beforehand for various reasons. But
yeah, to shrink the tumor.
But it wasn't a recurrent situation. Now, you, Paul, were taking on ADT for recurrence. So you'd had your treatment. You'd done, I think, whatever you did afterward. I don't think you did much afterwards. You decided not to do anything, if I remember. And then you started taking hormone therapy. So, the two situations are not exactly the same. The reason why I think Bob's doc is saying, look, your PSA has to get up to 150 is because he's saying, look, if there's any cancer, if there's any prostate cells that are left in your body, other than what maybe tiny little bits that might be around the surgery, we need enough testosterone to fire them up to make them express PSA.
Is that right?
In your situation, what we were doing was taking the testosterone out of your body and hoping that that would reduce your PSA. And if you still showed PSA whilst you were taking the LHRH drug, you would have been what's called castrate resistant, which wouldn't have been a good sign. Now that you're off the drug, any amount of PSA, any amount of testosterone in your body is going to be critical. I don't think the 150 is the same situation. The fact that you are now a year out with testosterone of 150 and still showing less than 0.1 is, I would interpret that as being a pretty good sign. But the situations are not the same. Len, was I being clear? Can you clarify a little better for me?
Not really. I think you did a pretty good job there, Rick. I would agree with you that in Paul's case, having what was your T level, Paul? Was it 150?
Yeah, I've actually forgot. I can't remember if I'm at 125 or 150. But it's been going up 30 every 6 weeks. Yeah.
Yeah. So I mean, that's a significant level of testosterone, and the fact that your PSA is still undetectable, I think that's a very good sign.
Right. That's what
it's meaningful. You know, I would agree with Rick. Definitely meaningful.
Yeah.
But Bob, you have a slightly different situation, and so I think that with him saying he wants to see it get up to 150 is because he's really not sure what's there. You weren't on long term Lupron as Paul was for 2 or 3 years. So that's also another factor in why it's taking Paul longer to recover.
Right. There may be another thing for me too, which is I think I remember being told that after the prostatectomy, the PSA is not necessarily valid or meaningful necessarily for like a period of 4 or 6 weeks anyway. Is that right? Or
yeah, I remember that. I had to wait, I don't know, 2 months or so before they wanted me to check my PSA.
Yeah.
I'm not sure why.
Well, that may have something to do with it too.
Yeah, they usually wait at least 6 weeks to do the first PSA. I don't know why. I have no idea. I don't know. I don't know. I mean, I'm wondering whether it has something to do with PSA getting into your bloodstream through the surgery because they're severing prostate tissue. And I just, that's a pure guess. I have no idea. We need a urologist on the call or somebody with more knowledge. Anybody have any idea why you have to wait 6 weeks? No? Okay.
Rick, I did have another question. It's a real quick one. I heard last week you said that glucose feeds the cancer. Glucose is not good for cancer. Does that mean you should be on a low-carb diet? Because carbs turn to glucose.
Probably, yeah. I mean, carbs do turn to glucose, and we know that glucose feeds it. So I don't know, Len.
Well, I would say that I believe most oncologists are of the mind that prostate cancer, compared to other cancers, is a slow-growing cancer. It doesn't utilize glucose anywhere near the extent that other cancers do. So, I mean, that's why the FDG scan is not particularly good for prostate cancer. That's all based on glucose uptake, and prostate cancer cells don't grow that fast. So they're going to be taking up glucose in a manner that differentiates it from the normal cells. That's why the scan is not good for prostate cancer. So in general, for good health in general, avoid glucose. I wouldn't avoid, avoid sweets, processed sweets. I wouldn't worry about, complex carbohydrates. That's where you get a lot of your fiber from, which is good for you.
Yeah, okay.
I mean, I can tell you that when the cancer advances significantly, when you've got real sort of rampaging metastasis, I think prostate cancer consumes a lot more glucose at that point. But that's not the same as in the earlier stages of the disease. So,
and often at that point, Rick, the prostate cancer cells are using a different type of metabolism to as an energy source. So they don't rely as much on glucose. I forget the details, but you know, it's mutated so much at that point that it's not typical metabolism.
okay, well, we will finish in a timely fashion today. I really do want to wish all of you a really happy and peaceful Thanksgiving with your family, your friends, whoever you spend it with. It's a good time to think about the fact that for some of you, you've made it pretty much intact through another year. And for others, you're doing real well on whatever treatment. And we have to express gratitude for all of that, amongst everything else that's on your gratitude agenda. We will, if I can get my act together, we may try and get something out for Giving Tuesday. But for us, it's just, you know, we tend to sort of do an end of year appeal. And we will be doing that this year. So just keep us in mind. We all recognize it's a different year from a tax standpoint. But I don't know whether we'll throw something out with everybody else for Giving Tuesday. Your inbox is going to get very cluttered with people asking you to remember them on Giving Tuesday. We hope you remember us throughout the year and especially at the end of the year. So I wish you all a very happy Thanksgiving, and the next meeting will be on Monday the 2nd, right? Monday the 2nd, which is next Monday. Geez, next Monday. Okay. What can I say?
Okay.
All right. Happy Thanksgiving, everybody.
Happy Thanksgiving.
Happy
Happy
holiday.
Thanksgiving.
Happy holidays. See you next year.
Good night.
Next
Good
month.
night.
Good night.
Bye.
Be well.